Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the files pod located directly below the presentation. It is now my pleasure to turn the conference over to today's first presenter, Chris Hunt. Please go ahead.
Thanks, Stephanie. Hi, everybody. This is Chris Hund, Senior Director with the Center for Health Innovation at the American Hospital Association. Thank you so much for joining our June 2020 AHA Team Training Monthly Webinar. Our topic this month is on telehealth and how telehealth and teams transform healthcare. So thank you so much for joining this month, and happy summer. So just some rules of engagement. Pretty typical from every month. The audio for this webinar can be accessed in two different ways. So the way that I like to do it is through my phone, because that's usually a little bit better connection, especially if you don't have a very strong internet connection. If you do listen through your phone, you're going to want to mute your speakers on your computer so you don't get a weird echo effect. Or if you've got a nice strong internet connection, feel free to listen through your computer speakers. All hyperlinks on the screen are active if you click on them, and will open up on another page so you won't lose the presentation. So as we go along, if you run into any interesting hyperlinks, feel free to click on them. We'll have a Q&A session at the end of the presentation. So the way we like to do this is we like to have everybody go into the chat box that some of you are already using and type in the question there, and I'll gather all the questions and then curate a Q&A session at the end with our speaker. If there's any questions that are left over that we don't get to, don't worry about it. That's okay. We'll work with our speaker to get those answered, and then we'll get the answers out to you. So hopefully you have lots of questions, and this sparks a lot of interesting thoughts and ideas. All right, so to receive continuing education credits, we partner at the American Hospital Association with Duke University to provide this free hour of CE credit. So in order to qualify, you must have an active Duke OneLink account. If you do not have a Duke OneLink account, please download the Continuing Education Instructions PDF in the Files pod in the lower left part of your screen in order to set up your account and confirm your mobile number. This is a one-time setup, so you could use your account for all future AHA team training webinars, and if you join us on a regular basis, you probably already have an account. So just use your old account. We'll share this again at the end of the webinar, but to get credit, you must text the following letters: RORQOL to the number you see on the screen within 24 hours of the live webinar to receive credit. So if you don't do it within 24 hours of right now, you won't be eligible for CE credit. So we'll put that up again on the screen in the end of the webinar, but just wanted to give you the information right now too. All right, so some upcoming AHA team training events. So really, we're focusing in on our webinars right now, and so in July 16th, 2020, at noon Eastern Time, we have a webinar called Team Overboard, How to Get Your Team Back in the Boat. And what this is all about is, how do we refocus ourselves and refocus our efforts since we've really, had to deviate lately with COVID-19, and it'd be nice to get back on the path. So these are all about resiliency tools to prepare for the next challenge and how to get that momentum back. So that's what we've got going on in July. Also, I want to talk to you about our Mighty Network online community platform. So this is something that we launched last month, and a lot of people seem really interested in it, so we're glad that we're getting more members. So we're really proud to announce this. It's a community platform to bring healthcare teams together. Our mighty network will allow the community to support, connect, and share with one another. So that's really what this is about. This is about you all connecting together. So this platform will allow you to connect with your peers who share similar successes and challenges. You could share tools that you've created or request them. Maybe you're looking for something or looking for stories or content. We also have exclusive content out there. So right now that includes our Team Steps for COVID-19 training videos, as well as an updated slide deck for the Team Steps Master Training course, where we refresh the look and feel. So you can find these on Mighty Network and only on Mighty Network. To make this community a thriving reality, we need your help, though. So every time you contribute a story, experience, an idea, resources, you're really building on a collective knowledge base for your fellow members, for all of them to tap into. So this network will only be as powerful as what everybody out in the community does. So click on the link on the slide, and we'll also put the link in the chat pod, and you can start creating your profile and really start interacting. So I'd click on that if you can right now, and then you'll be able to go back to it later after the presentation. All right. So without further ado, I'd like to introduce today's presenter, Barbara Edson, who is a nurse and the Executive Director for the Virtual Care Center with UNC Health. And she is somebody who's been involved with Team Steps and other team-based care initiatives for quite some time. I'm really happy to have her here today. I know I say that about all of our presenters, but Barb is somebody that I consider a mentor, somebody who I used to work with closely, so it's a lot of fun to get her on today's webinar and to talk with her about telehealth. So without further ado, Barb, I'd like to toss it over to you.
Thanks so much, Chris. Can you hear me?
Yes.
Perfect. Okay, I just wanted to do a double check there. Good morning or good afternoon, depending upon where you are in the country. Thanks so much for having me come and present today. And as Chris said, a bit of a history with Chris and Team Steps and AHA, and really very excited to be here to speak with you today. Today we're going to go ahead and really discuss Team Steps and the application of some of those tools in telehealth. There was a lot of questions that came in beforehand related to some specific things around telehealth, coding, billing, technology, interpreters. But really, our focus today is going to be on teamwork, utilizing Team Steps tools within telehealth. And so we will go ahead and spend some time to discuss the process of setting up a program, first and foremost, how some of those changes happened pretty quickly in the events since COVID. We'll go ahead and look and compare some in-person processes to telehealth processes. And then we will go ahead and I'll give you some examples of Team Steps tools that could be used in inpatient workflows, as well as some in the ambulatory space as well. So we'll go ahead and move on to our first slide. So virtual care, and I have up here my first bullet, language, so many terms. Terms are very confusing for folks that are not familiar in the telehealth space, and there's plenty of terms that are used interchangeably. I want to go ahead and just kind of set the course of action here. We use virtual care as an all-encompassing tool. You will see information in different realms where they're like Health and Human Services for the Department of Health and Human Services defines telehealth really as the use of electronic information, telecommunication technologies that support long-distance clinical health and patient and professional health-related education, public health, and health administration. Big mouthful of terms. But I like to look at it, telemedicine really in the treatment of clinical care, I look at telehealth being a bit broader to encompass the education, the non-clinical, as the Department of Health and Human Services, goes ahead and defines. But then I look at virtual care as the overall digital bucket, if you will, that will go ahead and take into account really any mechanism of delivering, educating, preventing care in a space that's not in person. So I know that's kind of broad and big, but there are some terminology in a tool that AHA has, excuse me, which is a great tool called the AHA Telehealth Resources. And if you click on that link there, there's plenty of tools in there. And one in particular I'm calling your attention to is the Telehealth, A Path to Virtual Integrated Care. Came out probably in the end of 18, beginning of 19. And so by our means today in our post-COVID world, or our COVID world, that it is, it might be considered outdated. However, the information that's contained within there is not. It's just some of the things about adoption have really changed within the pandemic. So a great resource for you all to use. I call your specific attention to the 7 telehealth use cases, specific objectives achieved by telehealth, the things that you can accomplish, and then just overlay some of those things. We'll talk about that today, about COVID. And then hospital telehealth maturity model. I think that's really helpful as you start to assess where you are on your journey of telehealth or virtual care within your organization. So I would call your attention to that because I do think it gives you a good vision of the direction that you may want to take your program. So when we look at telehealth maturation and adoption, this is one of the figures within that report. This is related to the cultural attributes, and I can't say enough, as you all know, and because you're attending something around teamwork, culture is so important, and it is important in any initiative or any program that you're designing and putting in place, and it's no different within virtual care. So, but we're marching along these attributes and the maturation process to get folks there. And then what really rocked our world was the pandemic. So it was a slower, more deliberate, some states further ahead than other states, depending upon what the reimbursement models were in the states. But everything was out the window when March rolled around this year because of the pandemic and the need to really move into a digital world. So we'll go ahead and spend some time going ahead and looking at some of the things that we did to set up the program initially, and then how some of those things changed and evolved. So our program development, pre-COVID, it was very intentional, set about in 2017. UNC Health leaders got together and really decided that they wanted to have a keen focus for UNC on developing a program for UNC Health that would go ahead and look at alignment and would really center in on how we can align, how we can systematically, in a system manner, look at telehealth program management and support both the identification, prioritization, and implementation of existing programs and future programs. I want to be real clear. Telehealth's been around for a very, very long time. And so when we think about it, physicians and providers have been making phone calls to patients since the phone was invented, and so, or utilizing mechanisms other than in-person care. Our effort at UNC was really to go ahead and put some guideposts around that to go ahead and help providers with the implementation and sustainment, or if they already had programs in place, how can we go ahead and optimize those programs? So as I said, 2017, the end of 2017, they started with the Virtual Care Center. We did a lot of work around some strategic development foundational documents, setting up some guiding principles for the center. We had a governance structure in place, which, as many of you may know, governance structures in virtual care or telehealth for healthcare systems. It doesn't really fit in any particular area, but it fits in all of them. And so when we start to look at governance structure and organizational structure for telehealth programs, it's challenging because it goes across every aspect of the business. And so looking at where that governance structure is, it's complex. It needs to be very intentional of where it's located, and it will evolve over time. We learned some great lessons from the University of Michigan Medicine, around how they had set up some of their governance. PACE. The PACE was, for us, slow initially in 2017. At the end of 2017, it really kicked off in the beginning of 2018 for our center. And that was really because of the ability from a standpoint of finance driving or reimbursement driving the ability to go ahead and implement telehealth models. So we had some time to go ahead and do some use case development and optimization. I will tell you, some organizations have gone very deep. We've learned a lot from those organizations, going very deep in a particular area. Maybe it's an inpatient teleacute area, such as an EICU program or a telestroke program, or maybe it was an urgent care program that was a direct-to-consumer type of thing. And so we learned pretty quickly from others that we needed to go ahead and take not such a deep dive into one program, but perhaps to really start to look across multiple programs and then ask our leadership to help us prioritize some of those programs as we move forward. So we did a broad work and development of programs for the healthcare system. The communication of this was really done in a manner to go ahead and, if you think about targeted sales, that's what we were internally, looking at our targeted sales for our solutions, and then really keeping in mind that we needed to have some way to go ahead and look at metrics. Metrics are hugely important. And around the same time, the National Quality Forum came out with the NQF framework, the telehealth framework for measuring telehealth. And so we had that in mind as we were looking at developing programs and looking at each of those criteria within that framework to make sure that we were keeping those things top of mind. Post-COVID, wow, doors got blown off. So our government structure needed to become extremely nimble, not meeting once a month, but maybe meeting in a more daily, weekly fashion. We needed to really engage our stakeholders. Our stakeholders were starved for information. Our pace, as I said, was very, very fast. We ended up doing things on a daily basis, setting up communication and education 2 or 3 times a week for folks. And we really looked at how we could, over time, and this is an ongoing process, is really taking the use case development that we had done, where we had done all the right things about piloting and implementing and improving. You know, we did all our PDSA cycles initially, but with low adoption, we didn't really see the areas as cleanly to go ahead and understand where we could go ahead and optimize. So we did that rapid deployment of those tools, and then the communication, 100 times, 100 ways, all the time, and utilizing avenues that existed and then creating some new avenues for communication. Dashboard. We released an internal dashboard for our leadership so they can understand volumes, durations, all of those things, where we need to go ahead and target. But over and above that dashboard, I think what's really important is us learning from the data that's coming in so that we can further improve the end user experiences. And that's kind of where we are now. And I think it's going to be ongoing, like most things that we see in improvement. So what do we do at the virtual care center? What we really do is we look at strategy from the organization's perspective. We work on program development, okay, and those things can be down a service line, whether it's a telestroke type of program or something like that, or it could be really development of use cases. And I'll talk a bit more about the use cases as we move forward, but those are things such as the buckets that we put them in, and that AHA document will help with some of that terminology, but I can go through that in just a minute on the next slide. Internal and external communication, it's really building the awareness for everyone of all of our virtual care offerings and things that change. And that became a huge issue for us when we talked about compliance and reimbursement and coding and legal things and diminishing risk, all of those things that for an entire organization and mobilize an organization of 35,000 or more employees. Looking at performance monitoring improvement, I alluded to data and metrics. That's very important to us, and I think it's going to become more important in our future, and we can talk about the future, where I think some of the future is going, but I think looking into the glass ball, there's lots of folks that would say they don't think that telehealth will go away anytime soon. So we can discuss that at the end. And then organizational learning. This is new to folks. Folks have not practiced in workflows perhaps such as this. I told you it's been around for a long time, but not all aspects of it. And understanding all of the parts of each of the use cases or each of the mechanisms that we go ahead and work with our patients and family members with virtual care and with each other, providers to providers. So creating that organizational learning is really important. And we leverage things in the communication realm and in the organization learning realm and our metrics in our internal websites that we've created for our users. So it takes a team. And I truly mean this. You know, we think about teamwork in our clinical areas. We think about teamwork. I know Chris and others, we've done work in the non-clinical areas of how the importance of establishing teams and leading teams and all of the things that go along with that. But I'll tell you, for telehealth and what we've just gone through from a rapid adoption perspective, teams are extremely important. Prior to COVID-19, we had already established some of these teams. They were not moving as rapidly because the pace was slower, but we had established a compliance and reimbursement risk legal team that we would be in touch with because we had started to work on policies and things around telehealth and understanding some of the regulations that exist. We had started working in the reporting and data and analytics piece of it. And we had started working with communication and marketing on some of our direct-to-consumer products, such as our urgent care, our online urgent care. Education and training was hugely important. We experienced that in our pilots and leveraged some of the things that we use frequently at UNC Health, which is tip sheets and videos and things like that for our end users. And then I cannot underscore the importance of the technology and equipment, folks. Our ISD department has been instrumental in really helping us, whether it was to go ahead and navigate a program or a use case that was delivering third-party services, because we have some of those at UNC Health, or was it to go ahead and build something off of our EHR platform? So those all are extremely important. The things that are in the center there, those are the folks that we serve. We serve our staff, our families, patients, providers. They're all integral to getting the voice of the customer into what we're doing. But the departments that we rely upon is the expertise that exists today in probably every one of your organizations, as it does in UNC Health. So the end user groups, patients and families, we have to yet develop that group. That will be one that will be being developed. Would love to have said that we were able to go to that one first, but the pace that we were dealing with, it would not allow for that. Providers and staff, we have stakeholder meetings. They were very frequent with our stakeholders that were interested in really understanding, utilizing, and helping us develop the program. And that stakeholder group became much more active in the COVID world. We had individuals that were interested in pre-COVID, but in the post-COVID world, we had a whole bunch of people that wanted to go ahead and be in the space and help us out. And then, as I said, I went through these different groups that we have formed that meet on a regular basis. Some of them were daily, meeting daily and pushing out materials daily. Others were 2 times or 3 times a week, and then some of the cadence has now moved to once a week, depending upon what the work is that they're doing. So really important in setting that up. It's a team. The team needs to have goals and objectives as we move forward. These are components that make a telehealth program successful, and it's really leveraging all of those great folks that exist in your organization today to make it successful. So team tools used in the development of a virtual care program and the products and services that are developed that come from your virtual care program. Team structure is one. I just spoke about the team structure. Size and membership is important. Making sure you have the correct leaders on the team. So really diving into what that composition needs to be. Leadership itself, coordinating the activities of the group, making sure that we're setting about goals and direction that we're trying to go ahead and make sure that we're taking into account the expertise that's there. And then really our job at the Virtual Care Center is to work across all of those teams to deliver to those end users and taking into account the experience of those end users. We use things such as briefs and huddles and debriefs. Very familiar with those, and I'll give you some examples as we move forward. We probably don't call them out as much as saying, hey, we're going to have a huddle or a debrief on something, but we do use them both, from an ad hoc standpoint and also a bit more intentionally as we run into some issues. Let's see, situation monitoring, making sure that we're all in the same movie, making sure we have that shared mental model, I think is important. And that's really important in telehealth because of the new terms for folks and folks understanding. And we can have conversations, and we often have this, and we will go through a whole conversation, and then they will use a different term that means something totally different at the end of the conversation, which means it's a re-education. And we're going to be in this space for quite a while as we go ahead and educate the masses around telehealth. Looking at communication, again, it's not what you say, but it's what they hear. So from a communication standpoint, we need to go ahead and really work very diligently on communication strategies. And we have changed some of that up. We will continue to work from an internal aspect. And then there's external. There's lots of work that needs to be done with patients in our communities and our families and caregivers to understand. If you think about it and you think about where the public is and sometimes some of our providers, if you go back to the days when we had telephones that were party lines, and I'm not that old, but I do remember those. So party lines moving to a rotary dial phone, moving to a push button analog type of phone, moving to a bag phone in your car, and to a flip phone, and then eventually to the computer that we all carry now in our pockets. That was an evolution over many, many years. And if you think of what we're asking our patients to do on something that is very, very important to them and our providers, is to go ahead and utilize technology and learn it very quickly. And there's different mechanisms in which to do that. So communication cannot be stressed enough. Education around these things for our patients, we need to make it as easy as possible. And we also need to work on that end user interface and understanding from our provider standpoint. Mutual support, being able to anticipate others' needs. And I think that comes through really, we've gotten better at that. I think we still have opportunity in that area to understand those things and really try to work to make it as easy as possible, and then to help out with the workload that folks are dealing with. Many organizations have set up centralized services around support of telehealth. I think there's lots of opportunity nationwide to go there. So I will go ahead and call your attention down here to the AHA team training homepage. And some of their tools and materials for team tools that the AHA Center for Health Innovation has eloquently put together and have for your use. We do talk about team steps and the collaboration that happens between the Agency for Healthcare Research and Quality and Department of Defense, and utilizing those tools along the way. So the next thing I want to go ahead and talk to you about is use cases. You heard me mention virtual care use cases, and we adapted this from that guide that I spoke of early on, but we use this all the time. We're trying to get people to think in categories of what they are trying to accomplish. We always start a conversation of what problem are you trying to solve, trying to get to that common goal that teams need to go ahead and think about as they're trying to go ahead and leverage tools and technology. So provider to provider, or P2P, and provider to patient, which we call the direct to consumer, okay, or DTC. In this realm, we have highlighted some of the things here and that I'll go ahead and address and speak to, but consult, eConsult specifically, that is actually a templated consult. We use Epic at UNC Health as our EHR, and it is a templated communication within Epic, and we have them both in our ambulatory and our inpatient environment. Consults on the phone, as I said, those have been being done for a very long time. Teleacute services, you've probably heard of many of these, telestroke, EICU, telesitting, all of those types of things. Telemetry. And then we have the other category, provider to patient or direct to consumer. You see e-visits, again, templated communication between a patient and a provider. Video visits, scheduled in the ambulatory space, on demand in the ambulatory space, and then what we call AV streaming, or in the inpatient space, a video visit. Billable telephone visits, My UNC chart messaging, that's our patient portal, remote patient monitoring, and second opinion. Some of these use cases we have done very little work, and we will develop them moving forward perhaps, or we will evaluate whether or not to develop them moving forward, things such as second opinion. Other areas we've done some more work, but for the most part we've done some work in each of these areas, probably except for the second opinion. The teleacute care, we've done a lot of evaluation work. We have some third-party folks working in our system. We have some internal folks working in our system doing some of those. But for today, we're going to go ahead and look at examples around eConsults, scheduled ambulatory video visits, and some AV streaming. So, terminology again, you'll hear me sometimes say things like asynchronous or store and forward. Think about email when you think about something like that, or synchronous, real time. Think about video or audio when you think about synchronous versus asynchronous. And we've been in all of those spaces, as many of you have been. So eConsults in the inpatient and ambulatory settings. They are a specific Epic at UNC referral type. and it's a process that's initiated by a requesting provider who is seeking guidance by either a specialty or a responding provider. And we use pretty broad terms like that because it's not always a primary care provider going to a specialist. It could be a specialist going to a primary care provider to understand control of hypertension medicine or something for a particular patient. So it's requesting provider, responding provider. We have several specialties, both for inpatient and ambulatory eConsults that have been put in place. It is you'll see over here a little guide that we look at. We think about who are we targeting, who's involved, what are the costs to go ahead and initiate something like this, where's the adoption, where do we predict the adoption will be, what kind of platform are we going to use, does it directly interact with the patient, what technology can be used? What is it going to be some of that store and forward that we just talked about, or is it going to be more in the asynchronous streaming? We get into that with, and then we talk about how quickly could that service be? Is it less than 48 hours, or is it going to be more than that? Is it going to be 24 hours? What's our turnaround time? And those things are all moving targets, right, as we develop a program, and then we go ahead and evaluate it and optimize programs. What are the payment and reimbursement implications? And then what is the organizational risk? And so we look at those things. If you pay attention to the right side of the slide, that's just a high-level summary, but something that you can think about as you roll out programs within your own organization. We think about the operational workflows. Our goal, looking at adoption of virtual care, is what is the technology lift, how integrated is it into our electronic medical record, and then really what is the operational workflow to go ahead and move things forward. What education is needed? How do we do that education and training to be the most effective? And then any additional specialties that we need to go ahead and consider that would really help out our provider group and our patients. So we think about teamwork within eConsults. What did we use to go ahead and set them up? It was the provider stakeholder group, the voice of that customer. It was a provider-to-provider workflow, making sure that we had ISD with the help of the build and the optimization of that. We had, obviously, compliance and reimbursement and risk team, and education and training. Those are all very, very important to the development of the program and the implementation. Implementation, getting someone who is a champion. You've heard this before if you've been around quality improvement. That is very, very important to us because it really helps navigate that end user experience and the voice of the customer. The education and training team, can't be underestimated for the work that they do. Our tip sheets are very heavily used. Those are the guidance for our providers. And then communication and marketing, making sure that we're communicating out to others. We don't particularly market these at this point, but in the future they will be marketed internally, I'm sure. And then data and analytics, making sure we understand how long does it take to do one of these things, how many are we having, who is doing them, all of those types of things. And then how do we go ahead and look at things where we could optimize maybe that workflow, taking some of that data and analytics. The COVID application and benefit, really it's expanding our access to our specialists and really increasing turnaround time when we think about access. So if it is a short, one of our medical director that we work with, he will say, Barb, it's kind of like when I used to be able to walk down the hallway of a hospital and I would get an opinion from and I would have a question perhaps that would be cardiac related, and I would pass the cardiologist in the hospital and I could say, hey, I've got this patient and I need to go ahead and understand medication for that particular patient. I have a question for you. They're very targeted questions, usually around more low acuity types of things that don't require an exam or the patient being referred into a provider. How many times do we get that right? We get it right a lot. There's only, I would say, a very small percentage of these that actually, once it goes to the responding provider, that the provider has to say, hey, you know what, I really need to see that patient in person. And that's totally up to between the requesting provider and the responding provider. But in actuality, they really can go ahead and help with access to get those questions answered in a quick turnaround time. It can diminish the need for traditional face-to-face treatment for appropriate consults. So consults that may have come in before that were really ones that could have been done through a quick email exchange type of situation. And it can reduce the use of PPE. So if you don't have people going into a patient's room, if it's not necessary, there's going to be times, trust me, that it's necessary to go ahead and do that. But can we go ahead and look at the amount of PPE? And that has been a big focus and a goal from the organization's standpoint in all organizations as we've moved through the pandemic. So when we think about tools in the eConsult development and implementation, you're going to see some things that are going to be consistent across the examples that I'm going to go ahead and give you. But you will see team structures there, leadership, what are we trying to solve by doing this, the situational monitoring that I spoke of before, and then, of course, communication. All of those tools are very important and can be used. Ambulatory scheduled video visits. Again, you'll see over here the little grid of, the target audience and cost to implement and all of those things. But really what these are just as they say, and we don't call them virtual visits. We don't call them anything else. We really spell it out so people can understand what we're talking about. Nationally, it's the largest increase that we've seen in all of our virtual care tools, over 1,000% increase in these tools nationwide. That is nothing new to anyone who's been in the telehealth business. We have seen overloading of servers, not specifically UNC, but I'm saying, nationwide, telehealth companies gone up 800,000% in their visits. It's a provider-to-patient, direct-to-consumer workflow. Ours is we have an Epic embedded solution, which we use context-aware linking to do. These are all just terminologies to go ahead and describe the technology. And the patient enters in through our patient portal, and the provider enters in through their scheduled video, through their schedule, and they see a video visit there. The solution has been optimized over time and will continue to be optimized. New features are being added routinely, and we'll continue to go ahead and work with it. This has not been without problems. There's plenty of places for failure for this when you think about the bandwidth of where the provider is located. If they're within on our network, that is not an issue, but if the provider is doing these from home because maybe he or she is in quarantine, if the patient bandwidth at home or they have no bandwidth, maybe they don't have a network, maybe this needs to be a phone call. So those types of things along with the technology that folks have. And so we have lots of points of failure in telehealth. And what we need to do is work through that to get to consistent standardized processes so that we can diminish those failure points and work with an understanding of the end points, both the patient endpoint and the provider endpoint, to go ahead and make the experience as successful as possible. We also have used non-embedded solutions such as WebEx Teams and Doximity within our organization. We will always drive first and foremost as you look at the maturation model for the integrated solution within the EHR, which is our Epic embedded solution. The reasons for that are really to go ahead and make sure that we can have a common place for the portal for the patient to come through and a patient experience, as well as for our providers, but also we're able to build in things around compliance and billing and all of those types of things that are so important to these visits as well, and security, HIPAA, all of those types of stuff. So our scheduled video visits teamwork, again, brought together a large group of folks. We are still meeting with those folks. And, we have really worked to engage them. I will say this has probably gotten out of all of our use cases, probably the most attention and focus on this because of the increase in volumes here, and really patients being afraid to come get health care. Let's see, what else? So the implementation of this, really, we started pre-COVID, piloted, did a small group, but with COVID-19, overwhelming demand, abrupt and immense implementation, education and training and support had to scale very quickly, and as well as the communication has. So the benefit here, we can expand our access, we can decrease the necessary face-to-face, and decrease exposure risk for patients and healthcare providers. These are tools that were used there. I will want to spend 1 minute here. I know that we're running close to time, and I know we want to have some time for questions. But team structure. There's a team that created the work, right, that we've talked about. But here, we've gone back and we've had to huddle, on really the direction that the program was going when we were running into a lot of technology issues and communication problems and education problems, and pulling a group back together and saying, we really probably need to look at the in-person workflow. How do we mimic that in-person workflow? So instead of having providers without the support of the front desk people or providers without the support of the MAs, how do we go ahead and look at the different roles? How do we engage those roles in that team? And how do we go ahead and do that to make it the most effective appointment possible? We do that in our in-person visits today. How do we go ahead and leverage that from everything from scheduling the appointment to going ahead and preparing for the appointment, and then making sure that we're doing our appropriate screenings and everything else, and getting the appointment where it needs to be for the provider, and then closing out the appointment. So really taking into account the team that needs to be involved. And we learned that, I'll be honest, a bit of the hard way by not putting those pieces of information out beforehand. The other tools here, led by ambulatory leaders and stakeholders, really identifying opportunities to optimize that. That's an ongoing process, and an ongoing process with communication. Inpatient virtual tools. So looking at this, we use AV streaming. We started out in the ED with drive-up triage, utilizing a streaming mechanism embedded within our Epic solution for providers who are in a pit to go ahead and really do an evaluation with patients in their cars. That then quickly ebbed into how do we do it in rounding, and then how do we deal with consults. And so we have been able to go ahead and do that. We bring other members into the team besides physicians and nursing. We bring in someone sometimes called a telepresenter. That may be a physician or nurse, or may not be. It's someone who really goes ahead and helps work with the technology to make sure that we can get the AV stream running and working. And then we have all different devices that we use at the endpoint of the patient and at the endpoint of the provider to go ahead and accomplish this. I think the big lesson here on this one is looking at teamwork as it relates to putting the team together to do this work is important. The technology's been huge, again, as well as compliance, where we publish internally a playbook, a guide that tells us everything you wanted to know to execute a particular workflow. And it's got all the components in there, and it's like a one-stop shop that we have for our folks. And then we look at really the implementation of this was pretty quickly implemented as the pandemic escalated, and we needed tools within our inpatient space. Goals really and this one is super important because as we utilize different people to go into the room to do AV streaming where appropriate, it's not appropriate for every patient, we can really go ahead, if we keep the goals front and center, which is to decrease exposure or decrease PPE use, and yet allow the big teams that normally go ahead and see our patients access to the patients. This one's really important to understand what the goal is that you're trying to accomplish, not to disenfranchise anyone that you have to go in the room, quote unquote. It's really to go ahead and keep the overall team moving forward and make sure we're meeting the needs of the patient. I'm going to go ahead. I know I've talked pretty fast. Same teamwork types of tools, implementation here. It is a partnership between operations and providers to go ahead and look at AV streaming and with the patients as well. We have brought patients into that using something called MyChart Bedside, which will be released in the coming weeks to our institutions. So, in summary, I know we have 10 minutes left, and I flew through the tail end of that presentation, but really there's plenty of opportunities to expand the team to include patients and families, and I think that's where we would like to go next at UNC as we start to work in this area. Working in virtual spaces is new to a lot of people, and even to get together teams, whether it was you were used to going to conferences and now you're doing your work attending a conference such as this or meetings such as this, the same thing will have to happen to gather some input from our patients. So how do we do that? And I think that's the path that we'll be working forward with. How do we go ahead and look for opportunities to really develop even further our existing teams? How do we add structure to that so that we make sure that the right hand knows what the left hand is doing? I think we've been pretty good in centralizing that underneath the virtual care center. However, we have a lot of people within our healthcare system, and we serve a lot of folks in North Carolina. So how do we go ahead and do that in a meaningful way? We have opportunities there, as we've learned in COVID, and we knew before, the social determinants of health and being able to make sure that we can meet the rural areas that don't have bandwidth. How do we go ahead and do that? Do we set up kiosks in a church? I mean, what does that look like from the standpoint of making sure that we can care for our patients, minorities, and the like throughout the state of North Carolina? Virtual care is going to continue to grow and evolve. Predictions, it's never going to be returning to pre-COVID state. You heard me say that early on. I really don't believe it will. I think once consumers, adopt technology, it's going to be hard to go back. And really, there's times when virtual care is very effective and should be used, and there's times when it should be in-person care. And really navigating through those things is I think, the job of our healthcare organizations and our leaders and our patients and our providers to go ahead and do. Teamwork tools should and can be employed in development of a program and development of really being able to go ahead and develop programs that can be expanded. So looking at how those tools can be used, I think, is going to be really important, especially we have to be a little bit more diligent, I think, in our space when we're virtual to over-communicate perhaps or deliver communication in different mechanisms. So I'm going to stop there. I know that we've only got about 7 minutes or so left. And Chris, I'm going to go ahead and punt this back to you and see if there's any burning questions you want to go ahead and tackle.
Yeah, sure. Thanks, Barb. That was a lot of great information. And yeah, we do have a lot of good questions here. Let's start with something you were talking about towards the end there. Let's start talking about other members of the team that maybe aren't often thought of because they're not part of the core team, of like the core clinical team. So let's talk about patients and family members. How are, for example, are you using telehealth to communicate with family members during an inpatient admission for somebody? Is this being utilized that way?
Yeah, we actually have the ability in several of our use cases, Chris, to go ahead and add a family member in. So, okay. You can add an interpreter in. You can add in a resident. And we really recommend, if it's for social interaction, fine, they can use different technologies. So most of our technology that we use for our telehealth programs, it's encrypted. We have gone through security checks. We are making sure that it is very safe and secure to use. And so those instances, we tend to use our technology, have a connect button for a third party to come into that particular experience.
Got it. So that kind of, that there was a question about how patient privacy issues are being addressed, and it sounds like, and it says both on the provider side and the patient side, so it sounds like technology-wise, that's there to support the privacy. It's just, down to location then of where maybe the patient is to be having that visit, right?
Yeah. I think where our opportunity lies, Chris, so we're just getting into the patient experience realm, and, we're doing a couple of things there. We're looking at doing some quick, calls to patients to find out about their experience and learn so that we can adapt, and move forward doing some of those qualitative types of things. And then, obviously, we have a vendor that we use for patient experience, and we've just recently implemented that. But I think over and above that, we need to bring the patient and family into the development process within virtual care, and I think that's where an opportunity lies for us in our future.
Are you using any sort of traditional patient satisfaction surveys?
Yeah, that's what we just implemented about a week or two ago, maybe a couple of weeks ago.
Got it. So, you were talking there at the end about how are we going to, tackle the problem where, some communities may not have solid internet service or, anything along those lines. So who besides the technological hurdles that might be there, are there other patients that are at more risk because of this era of telehealth?
Yes, I think there are. I think the underserved, it's no different than I think we see in some of our other areas. We published a paper not long ago, within the last couple of years, once we had implemented our on-demand service, about healthcare deserts, if you will, areas within North Carolina that have no access to either a primary care physician or a pediatrician. And looking at how programs such as this can go ahead and help in those areas, but they can only help in those areas if they have a device and if they have internet connection. And so one of the things that, I would encourage people to look at is where is that located within your state. In our state, and I imagine like most of yours, schools are very well connected. So that's one area to go ahead and think about. The other areas you'll see maybe a church or a business could be well connected. And how do we go ahead and reach out and really take away? Some programs are doing burner phones. They're buying, we haven't done that at UNC, but they're buying burner phones and handing out burner phones because it's easier to go ahead and do something like that and less expensive. So I think there's many different ways, and I think we just have to be creative to do that because we can't disenfranchise using technology to minority or rural groups.
Are you with those individuals, those vulnerable populations that are often suffering from multiple chronic diseases, different issues? How are you connecting in with tech to do, checking in on vital signs, chronic disease management?
Yeah.
I know it's a big question to ask at the end.
Huge question. Huge question. I think, we have some great researchers, and, one of them comes to mind who has worked in the pediatric diabetes realm and has looked at diabetes care in adolescents. And we all know adolescents can be sometimes non-compliant. She's looked at it from the standpoint of being able to go ahead and keep her patients, if you will, fine-tuned. And it really is behavioral change. You know, I do the same thing with programs, you know, for myself, going ahead and looking at exercise and things like that. If there's a feedback mechanism to you, the likelihood of, and someone paying attention to that, the likelihood of you changing some of those behavioral choices may be present. But we need to go ahead and get better at that. And I think telehealth gives us a unique opportunity to do that, whether it's biometric monitoring that's done through Bluetooth application, or, as importantly, it's the behavioral modification. And then we have to go ahead and deal with the flip side of that, Chris, which is all of the information that is coming in to providers can be overwhelming. How do we sort through all of that and make sense of it to help our providers as we think about using these tools?
Yeah, that makes sense. Oh, well, there are a lot of great questions that we have that we will get to you for people to answer, for you to answer for people, things on regulations, things on different states and the ways different things are working. So sorry to all the folks that sent us this, but we'll make sure to get those. You'll receive an email shortly, everybody. We really value your feedback, so take a moment to fill it out if you can. Don't forget also to create that Duke OneLink account to get your CE credit if you haven't done so already. And as promised, here is the phone number again, as well as the code of RORQOL. So make sure you do that within 24 hours to receive credit. You're not going to receive a certificate, but you do receive the credit. So with that, I'd like to thank everybody for attending the webinar today. And Barb, thank you very much for the in-depth presentation.
Thank you so much, everyone. Appreciate your time today.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.